So, good morning, everyone. Thank you, Dr. Landy, for the invitation. It's a pleasure to be here in the morning to speak to all of you. Since I've been practicing neurosurgery since 16 years ago or so, functional neurosurgery has been a passion of mine. And the management of chronic pain represents the majority of patients we have in the subspecialty. Then I was thinking, what would be interesting for our residents and faculty on a Thursday morning to hear about? It's almost Friday. Then I thought about the management of low back pain, because first we have an impressive spinal surgery division here in the department. And also it's so common, low back pain, that one way or another is going to be useful, even if the colleagues don't share the same interest. So without further delay, let's start. I don't have any relevant disclosures to make about this topic. During the presentation, we're going to see some historical aspects. As I learned with Dr. Badu, that if we don't know our past, we're likely to make the same mistakes in the future. So understanding a little more about low back pain, the concepts within the condition, especially about patient selection, I'd like to highlight this topic because I think it's the most important. If you don't select well, you're not going to have your results. We're going over surgical procedures with a video and also different systems and outcomes. So briefly, the idea of using electricity to treat chronic pain is not new. Over 3,000 years before Christ, the Egyptians started using catfish for this purpose. The Greeks used the torpedo fish to treat migraine and gout. And in the end of the 18th century in Italy, Luigi Galvani introduced the concept of bioelectricity, which means delivering electric current to nerves to induce muscle contraction. But it was his cousin, Giovanni Aldani, that conducted the first experiments in humans. He used recently decapitated heads of prisoners to apply electric current, and he observed facial contractions. Some people even say that those experiments inspired Mary Shelley on her novel, Frankenstein's Monster. In 1874, Dr. Bartholow introduced the concept of electrotherapy. It was a patient with basal cell carcinoma that had the parietal region exposed, the dura, in fact, and it was infected. So he believed that delivering current to improve the vascular system at the area would be of advantage. So he stimulated. And the systems evolved until we have the portable transelectric cutaneous nerve stimulation system that is commonly used with good results for neuropathic pain and musculoskeletal pain. Well, talking about invasive neurostimulation, the goal today is not to cover all the approaches we have with neurostimulation. The idea is to focus in spinal cord stimulation because it's the most common procedure done and it goes closer to our specialty, but also the peripheral field nerve stimulation. It's very useful when patients undergo surgery and the incision presents neuropathic pain, chronic allodynia. They can barely touch and it triggers the electric shocks. So peripheral nerve field stimulation, peripheral nerve stim for facial pain, for example, the spinal cord is we're going to talk. And in selected cases, deep brain stimulation and motor cortex stimulation can be applied. Well, by coincidence, in March 55 years ago, the spinal cord stimulation was born. It was the first patient was implanted by a neurosurgeon in Wisconsin, Dr. Norman Shelley. He implanted a patient that had bronchogenic carcinoma and pain in the lower abdomen, and it was successful. The pain improved. A few years later, another patient was implanted for cervical dystonia and spasticity. So that's the birth of the technique, and it developed until now, when the neurostimulation of the spinal cord is replaced mostly. The ablative and destructive procedures is the most common procedure performed for neuromodulation in pain. So, but how does it work? The goal is not to go deep into the basic concepts here, but there is a multitude of changes we observe in patients that undergo the technique. Neurotransmission is markedly changed, especially with increase in GABA, serotonin, noradrenaline, and reduction in the excitotoxic amino acids like glutamate and aspartate. Vasodilation is a common effect that is observed in patients with SCS. Therefore, one of the best indications is the treatment of vascular conditions like peripheral artery disease and refractory angina pectoris. I remember my time when faculty in Germany, it was the best indication, the best evidence was for patients with vascular disease to use spinal cord stim. But also neuroprotection, synaptic plasticity, nociceptive signaling, and other aspects. It's even observed in CSF samples from patients that have successful SCS device implanted, that proteins like clustrin, mimicin, gelsolin, and VGF are in elevated concentration, showing a deeper impact in the nervous system. But before we dive deeper into spinal cord stim, let's take a step back and review some key concepts on pain. For instance, the International Association for the Study of Pain defines pain as basically two components, sensory and emotional. That's very important to remember because this will be useful when selecting patients and the strategy. Nociception is the unpleasant sensory component and the unpleasant emotion relay. Remembering that chronic pain is when the patient experiences this for over 3 months. I don't think I need to spend much time making the case why it's important to treat chronic pain. At a societal level, the impact, we know that chronic pain is a leading source of human suffering and disability, and chronic low back pain is the greatest cause of years lived with disability in the world. In America, the healthcare costs are estimated somewhere between $500 and $600 billion a year. So there is a very important societal impact as well at individual level. The psychiatric or psychological impact is devastating sometimes. We know that around 85% of patients with chronic pain have comorbidities like depression, anxiety, mood disorders, and drug addiction is a very common condition associated with chronic pain, especially opioids. So we try to move away from opioids as much as possible. Remembering that pain has two components, the stimulus, the somatosensory stimulus, and the nociceptive, and the reaction related to it. Some people would get angry, some would be depressed, some would be fearful, or even would try to use humor to overcome it. So if pain has two components, somatic and emotional, we think and we know there are two pathways involved, the lateral and the medial, meaning the spinothalamic tract and the spinal-reticular tract. Let's keep it in mind because it will be important later on. So the lateral component, the somatic component, starts with nociceptors that will perceive the noxious stimuli. It goes over the afferent fibers and the lateral spinothalamic tract, entering using the dorsal rootlets, entering the spinal cord, aiming at the dorsal horn of the spinal cord, where in the lamina 2 of Rolando or substantia gelatinosa, we see the interaction of the fiber planes, the A delta and C, the small caliber fibers with the normal sensation, the large caliber, large diameter fibers, the beta fibers. So the gate control theory was the principle used when we developed, when it was developed, the concept of spinal cord stim using tonic stimulation, the goal of increasing the normal sensation or the sensory input to close the gate for pain. Closing the gate means the competition that happens at the level of the inhibitory interneuron, blocking the pathway, preventing the stimulus to reach the brain. But this was not enough. The results with tonic stimulation were not as good as they could be. Therefore, the second component of pain was explored later on. So remembering that the emotional component, the medial pathway, some like to think that mnemonically, the heart, the emotions, they lie in the middle of the chest. So medial is emotional component, okay? Going in the spinal reticular tract, through the reticular formation up to the thalamus, using the widespread cortical projections of the pathway starting in the intralaminar nuclei, reaching the limbic system, especially the mesolimbic with dopaminergic input. So pain has not only two special components, but we can also classify the pain into basically two subtypes. There is the nociceptive pain, neuropathic pain, and mixed pain. Nociception is when the pain results from damage or potential damage to tissue, okay, like acute spine fracture or when you hammer your finger. Differently from neuropathic pain that comes from a lesion or disease that involves the somatory sensory nervous system. A good example is like phantom limb pain, CRPS, complex regional pain syndrome, diabetic neuropathy, and others. Okay, now focusing on low back pain. Is all back pain from spinal cause? We know that it's not true. Fibromyalgia, piriformis syndrome, myofascial syndrome, somatoform disorders, that's important to remember. Sometimes this can be really a problem to manage. If not identified, the patients don't get better if you don't address the psychiatric underlying condition. And multifidus dysfunction, this concept has grown within the field. So low back pain has a large number of causes. So this could result, low back pain or radicular pain can result from neurocompression, instability, or from like motor changes associated to degenerative disc disorder, like modic 1 in this example, or patients that don't have any of those issues. The spine was structurally already fixed by surgery. So there's no stability, no nerve compression, and they still experience pain. So that's why it's important to understand as much as possible from the pain your patient is experiencing to help him or her the best way possible. So let's start about the understanding of pain, quantifying it. The Vas scale is very useful and practical to do this. So it goes from 0 to 10, and the patient can quantify, and it's good to use as a follow-up as well. And to identify the neuropathic away from the nociceptive component is also important to guide medication, to choose between different procedures. The DN4 questionnaire points towards neuropathic component of pain. So each one of those questions, if answered yes, represents 1 point towards neuropathic. If you have 4 or more, it means you have a significant neuropathic component. So if the patient describes burning sensation, painful cold, electric shocks, if the patient reports tingling associated, any sensory disturbance related to the pain in the same dermatome, so as tingling, pins and needles, numbness, itching. In the exam, if you notice sensory deficits like hypesthesia to touch or prick, or allodynia, if the touch triggers painful response, it can be static or dynamic, but allodynia, those are all aspects that point towards a neuropathic component. All right. Remember the two components, sensory and emotional. Quantifying this is also important. And the short form of the Mcgill pain questionnaire helps us with that. The questionnaire has 15 points, and the first 11 represent the sensory, and the last 4 speak about emotional components, like if the patient describes a sickening sensation, fearful, cruel or punishing, tiring, exhausting. So it's important to identify the emotional component. There is always an emotional component, but if it is predominant, it guides you one way or another. To quantify disability is also important. The ODI index is very good for that. You have 10 questions, and after the calculation, 1 to 5 times 2, you quantify from 0 to 100% of disability. All right. It's not only important to see the clinical aspects of somatic and aspects, but also to identify comorbidities that can be actually the most important component in the symptoms, the origin of the symptoms. For instance, psychiatric conditions need to be identified like somatoform disorders or major and untreated psychiatric components. So neuropsych and psych eval are very important before we decide to move on to neuromodulation, for example. And extensive physical rehabilitation, the consultation with a colleague from the PM&R, this is key. You don't move before you're sure that the patient is not going to get better once the core strengthening exercise and all the rehab part is done. As well as medication. You don't think about doing neuromodulation for a patient that's having a good control or a reasonable control with Tylenol, for example. So where do we stand in medication? How do we think in terms of meds? It's important to have an idea so you can better understand to indicate or not. So typically in the pain realm, the WHO analgesic letter was the guide for escalation on medication. But it's important to remember that it was developed in '85 for cancer pain. Anyway, it's important to mention, you would start with non-opioids like acetaminophen or ibuprofen, and then you would escalate to weak opioids like codeine and tramadol, and the other opioids are all strong that we can prescribe. So they are the third, and then the fourth would be surgical interventions. But this was highly questioned before entering that. It's important to understand that adjuvant medication is important. It needs to be extensively tried, especially with the nociceptive component. Okay, like tricyclic antidepressants, SNRIs, and anticonvulsants. Okay, but so this was created a long time ago and for cancer, and it's been revised, and so it's not as valid as it was back in the day, up to a point that different factors, the evolution of system, the minimally invasiveness, the great results we have, the epidemic related to opioids with much more morbidity and mortality related, and especially in patients with chronic non-cancer pain, the recommendation now is to consider neuromodulation before the patients are addicted or even use strong opioids. That's important to keep in mind. So you don't wait until the patient is very dependent on strong opioids to think about neuromodulation. We're trying to move away from that. All right. So before going to neuromodulation, it's like when you build a house, you first think about the structure. You make sure your structure is solid. And then you think about the wiring, right? So conditions that are associated to instability, neurocompression, neoplasm, or infection need to be addressed. Patients that require spinal surgery need to have it done before you move to neurostimulation. All right. So the spinal cord stimulation is FDA approved for trunk and extremities, pain in the trunk and extremities, chronic and refractory. Within the spine, especially for failed back surgery syndrome, degenerative disc disease, radicular pain, again, once structural abnormalities were treated or excluded, CRPS, diabetic neuropathy was recently approved and it has a great result. And again, vascular conditions like angina pectoris refractory and lymph ischemia, the peripheral artery disease, because of the vasodilation that happens. Ignacio, I think you gotta mute yourself. No, it's Robert. All right. Okay. On occasion, the world experts, they gather and they publish the NAC consensus to help physicians in the practice to implant and to perform. I see Robert Jackson here. If you could mute, I'd appreciate. So how do we think about stimulation? This can be delivered basically using two sorts of leads, a percutaneous lead or a pedal lead. The percutaneous has cylindric contacts. The pedal lead has contacts that only face downward towards the spinal cord stem, and that's what we want to accomplish. We are here at the thoracic level. Remember the somatotopy that sacral fibers are more medial, thoracic fibers are more lateral, and the lumbar fibers are in the middle. And our goal is to stimulate lumbar and thoracic fibers to cover for the dermatomes where the pain is described as deep as possible in the spinal cord. And I think Dr. Monaco, for the illustration, this was very graceful from him. So if we see, if we think about the energy field, when we start to stimulate using those contacts from the pedal, it's it's energy sparing, because we're not wasting energy stimulating the dorsal aspect like the flavum. We don't want to stimulate that. So as we increase the amplitude to have a larger stimulation field and go in with the goal of getting deeper, we have this sort of impressions, the 3D representation. Differently from percutaneous leads, in which the stimulation field is like a sphere. So as you increase the stimulation field aiming to that part, what happens is that it goes also laterally. And here, remember, where the sensory rootlets are entering the spinal cord, and that is associated to side effects. So this limits your therapy. You cannot increase usually more the stimulation when using tonic because of the induced side effects. So that's an interesting concept, because this could be the explanation for what we see in a very interesting paper I'm going to bring on this slide. So when we think about, okay, we have our patient, we understood the pain, we understood the components of pain, we see it's refractory, there is no structural elements to be treated. So now we decided he's a good candidate for the therapy. We don't implant directly the full device. Always a trial is done before that. A trial means the patient has one of those leads implanted for up to a week, and then it's decided if the patient profited or not from the stimulation. Responders, by definition, are the patients that report a pain relief over 50%. And the trials can be done two ways. You can do a two-stage trial or a staged trial. This means a two-stage trial, the patients come and get a percutaneous lead, and then it's removed after a week or so. And if successful, we wait a couple to a few weeks, and then the patient comes for a full implant. Staged trial means one of those leads is implanted and connected to an extension cable, externalized to the skin, coupled to an external stimulator and the energy source. And if successful, the second part of the implant, meaning the pulse generator, the pacemaker, as they like to call the battery, is implanted. It's interesting to look into the recommendation of the NAC consensus that infection rate is close one to the other. In fact, the staged trial has around 0.1% of infection, almost 1%, and the two-stage trial, when everything is removed, 2%. So it's not relevant in terms of infection. It is interesting to see. And this is a very interesting paper that was published in 2017, where we see, let me make it larger, where we see that over 7,600 patients were implanted, okay, for a trial. And it talks about the conversion rate. Conversion means the patients that had the trial and it was converted into a full implant. And this over 7,000 patients were separated and categorized into the subspecialty that they performed the trial. They were separated in surgeons doing trials and non-surgeons doing the trial. So it is interesting to see. Well, here pedal was the choice that was used for the trial, pedal leads, and here percutaneous leads. The anesthesiology and PM&R, 51% and 42% of conversion to a permanent implant, while neurosurgeons 91% and orthopedics 82%. And this could be maybe related to the sort of stimulation field that is created with a pedal. That makes more sense. It has not only a wider coverage, but also targets deeper in the spinal cord. All right, so our patient had a successful trial, and then we decided to move on to the permanent implant. So I brought here the consensus that was published January this year and some recommendations. For instance, before going to the permanent implant, it's important to discuss with the patient where the IPG, the battery, will be implanted. It can be done in the abdomen, the front part, and the flank, and the buttocks. The goal is that the patient can choose a comfortable position and avoid like the belt line or any sort of compression that would lead to a wound dehiscence. Pre-op imaging is very important. We shall never implant an electrode, especially a pedal, without having thoracic spine MRI to rule out stenosis and other conditions, okay? So back in the day, the procedures were done awake, but it's been a long time that we moved away from awake procedures as they were related to decreased patient satisfaction, increased lead migration, side effects, and treatment failure. That's why we mostly, across centers, perform the permanent implants, non-awake, with neuromonitoring. So regarding the surgical technique, the recommendation regarding tissue dissection, if sharp or blunt, nothing special, at your discretion. The sort of approach can be open or using a tubing system. Most of the colleagues and centers, they choose a midline approach with a very small laminotomy to take advantage of the interlaminar space. Okay, so let's imagine that here is cranial and here is caudal. So the goal is to use the interlaminar space to place the pedal under the lamina, typically from T8 or T9. Okay, thank you, Dr. Wu, for this beautiful video of a case we did together. Here we see the flavum being carefully opened with an 11 blade, which renders a high precision for the procedure. And then once it's open, it's very important to assure that hemostasis is meticulous, because for two reasons: we don't see under the lamina, and we don't want to have have the risk for a epidural hematoma. This is the template. You see how flexible it is. It is placed before the permanent lead to see if there is any sort of resistance under the lamina. And once it's assured the room is open, it's important to take it out, give it time, wait to see if it will bleed, irrigation, gel foam, to be sure that it's absolutely dry. And then we proceed with the implant of the permanent lead, which is also very flexible and delicate. The one I typically use has 20 contacts to cover for both sides, to entire dorsal surface of the spine. The goal is to have the pedal aligned with the functional midline. So we do under general anesthesia with the microscope and neuromonitoring to be sure that we reach the functional midline. So if we think only about anatomy, this pedal here, it's likely misplaced. But using neuromonitoring, it helps us to see that it's actually very well placed, because what we're aiming is towards the coverage of both sides, including the dermatomes, where the patients report the pain. Okay, so not everything is beautiful, of course. There are complications related to this procedure as any other. So infections could happen. Typically, it's reported under 5%. Centers struggle to have under 2% of complete infection rate. It can be superficial, can be deeper, or even an epidural abscess where the entire system needs to be removed. Epidural hematomas can happen. It's reported around 1 to 300 cases. An epidural hematoma that needs to be promptly detected and treated and evacuated to prevent neurologic deficits. And lead migration. This is a more common complication that happens. Therefore, different systems have different techniques and anchor systems recommended. I brought some cases that are interesting for us to take a look. For instance, this patient that initially had a good response of the stimulation, but then the leads moved and he lost effect. He didn't want, and when we had to go to the OR to fix that. The patient wanted to minimize the chance of having a migration again. Therefore, we upgraded to a pedal lead. This patient unfortunately underwent a percutaneous sacral fusion, and the cables were damaged, and the lead had to be replaced. And then in this moment, we upgraded to a larger pedal with 20 contacts for a good coverage. And this case is very interesting. The patient lost the good effect from the spinal cord stim, and then one started thinking, was it a lead breakage? Is insulation? Is the battery? what happened? And when you see the lateral incidence, therefore it's always important to have both incidents, we see clearly what happened. The lead migrated to outside, completely outside the spinal canal. So, and let's understand more different concepts, different approaches for neurostimulation. Within the pain circuitry, we have tonic firing neurons and we have burst firing neurons. The first stimulation.
Hey, Joe, just before you leave the complication part of it, which I think is so important, one of the ones that you didn't mention is, and we've seen here before, unfortunately, is paraparesis or paraplegia with placement of the leads in a patient who had pre-existing thoracic spinal stenosis that went unrecognized. So when the leads were advanced into a very tight spinal canal, so the question is, you know, people need to know that it can happen, but the other thing is, what is the minimum required imaging studies, you know, before doing this procedure? Is X-rays enough? Obviously not. No. CT, MRI, how do you handle a patient who has tons of instrumentation and you can't get a good quality MRI of the spinal canal?
That's a great question, Dr. Levy. So according to the consensus, the NAC consensus was published, you need at least an MRI thoracic spine to rule out a stenosis or any other condition leading to a stricture or narrowing of the canal. In patients with large fusions, as you mentioned, typically what's recommended is a CT myelogram. So you can see then that you have room for the pedal implant. Thank you, Dr. Levy. So going back to the system, how do they work? So to account for tonic and burst firing neurons, in the beginning, the SCS was tonic stimulation. This means square waves delivered at a fixed delay. This would influence the tonic firing neurons, increasing the beta fibers activity, closing the gate and the substantia gelatinosa. That was the underlying idea. But then as the results were not as great as we wanted, so another strategy was developed to account for the burst firing neurons, where bursts of pulses were delivered. Typically, the bursts at around 500 hertz, 40 times a second, and especially with this system in which this powerful signal was created with a nonlinear charge accumulation approach. So this mimics more the physiologic neuronal firing, so it could mix better and to account for this pathway. So the tonic stimulation used to cover mostly for the lateral pathway, the somatosensory, and with the DR burst approach, DR stands for the reader, the neurosurgeon from Belgium that created this. Now, not only the lateral, but also the medial pathway, the emotional pathway, reaching the limbic system, is being influenced by this strategy. And it's important because sometimes the somatic component, the pain doesn't improve as much as we wanted, but we see the patients are more functional. They don't have the catastrophization, the anxiety, the fear, the depression is improved, and then they leave home, they go back to work. Sometimes they're functionally better. So that's an interesting feature of this approach. Even electrophysiological and metabolic imaging data showed the influence in the mesolimbic system going up to the anterior cingulate cortex, improving this. The clinical data with this approach, it's interesting to be shown in where the sunburst, it's called. This was published in 2017. We have the burst since around 6 years ago. So these 100 patients were randomly assigned to 2 groups, and they were stimulated for 12 weeks with either tonic or burst stimulation. And then after 2 weeks, the crossover happened, and they completed 24 weeks. So both groups had both modalities. And after that, they could choose which modality they would have for their treatment. And over 70% chose the burst DR. for different reasons, including that the burst DR is paresthesia-free. This could be an advantage. It's important before we move forward to understand that the very clear radicular pain with nociceptive component, like with shock sensation, tingling, allodynia, so the radicular, that typically comes after the nerve was injured by, typically by disc herniation or another condition that damaged the DRG. This responds very well to the tonic stimulation. Those were always the best results. But the back pain related to that, it's more complicated to treat because there is always an important nociceptive and emotional component associated for it. So back pain is harder. Therefore, we need different systems. And tonic stimulation is paresthesia inducing, and burst or the other modalities are paresthesia free. A different approach, it's very interesting, that came recently. This is called the differential target multiplex, or DTM. Differently from the other, this one targets at the glia. As we know, the majority of cells within the spinal cord is glia, and we see important changes in the glia when related to the chronic pain circuitry as it gets stronger. So in the preclinical data showed that using this approach with a different sort of stimulation in 6 different targets from T8 to T10, the mechanical hypersensitivity that's associated to chronic pain was markedly reduced, as well as the RNA sequencing showed the return to a more physiological gene expression pattern. And the clinical data, it came recently out, the result with 1 year of stimulation comparing the tonic stimulation, the conventional stim, with the DTM stim. So for low back pain, the response was significantly better. So the VAS score went down in 80% of patients comparing to tonic. But the leg pain, yeah, it's also better than the conventional, but it was not as impressive as we know that the radicular pain response, when a clear neuropathic component responds very well to the tonic paradigm. So this is another approach that can be used for spinal cord stimulation. It's called high frequency. When we talk about electrophysiology, anything from over 100 hertz is considered high frequency already. But this is very high frequency, 10 kilohertz. So the concept here is that you can go very deep in the dorsal aspect of the spinal cord, involving even the dorsal horn and the double DR, the wide dynamic range neurons that are hypersensitized in patients with chronic pain, that you can deeply stimulate and influence those neurons. It's a great system as well for the treatment of chronic low back pain and radicular pain. And it was recently approved for, FDA approved for neuropathic, diabetic neuropathic pain. And the result was impressive, like compared with, this is after 1 year, 6 months, and then 1 year later on, it kept the tendency. The conventional medical management and the spinal cord stim with high frequency improved very much the pain in this category. Okay, but then comes the question. Okay, it's beautiful. It works, at least in the beginning.
Joe, I just sorry to interrupt. Is that the Nevro system that you're
Correct.
talking? Yeah, and is that available here?
Yes.
Okay, and then there's, I don't know if you got the chat question in there.
No.
If you look in the chat box. Basically says in a patient with functional SCS requiring spinal surgery, what is the recommendation using monopolar cautery? Is turning off the SCS sufficient? Is it a consideration?
Depends on the system, but typically when patients undergo surgery, we have them turned off to avoid damaging the IPG. Monopolar is bipolar is always better if we can only use it, but it is safe as long as the insulation of the electrode is not damaged in any point, because if the insulation is damaged by the bovie, which that can happen, this will send the electricity and damage the spinal cord. But it's good to check every system with the company every time we have a patient like that. So, and in the long term, how is the performance as the years pass? Well, this study from 2018 with over 400 patients that underwent for primary or for primary implant for low back pain and radicular pain or barrier replacement showed the levels of satisfaction. They were very high. The follow-up was 2 years. It's considered long-term already in the neuromodulation world. So regarding improvement in pain relief, the satisfaction level was over 85%, almost 90%. Daily life activity, treatment satisfaction, and especially willingness to restart, meaning if you had to do it all over again, would you? Over 90% of the patients responded yes. So the patients continue to be very satisfied at 2 years after the stimulation. But yes, okay, 2 years, it's good, but 2 years, is it enough to believe the long-term efficacy is? So then I brought this study from Finland, and this was published in Neurosurgery in 2019. It's a very interesting study because it's a long follow-up, 20 years, with over 200 patients, and all patients are from a single institution because of the geography. But on the other hand, it's very homogeneous. Only failed back surgery syndrome patients implanted with pedal electrodes and no dropouts. And what we saw is that during the average follow-up was actually 6 years within this 20 years of experience in the center. Around a quarter was explanted for 19% of loss of efficacy. Again, it's important to remember that the technology evolved. Comparing tonic and the other systems that we have now, like burst, DTM, high frequency, well, this is mostly with tonic stimulation, but still 70% of patients profited long-term from the stimulation, which is encouraging for patients that don't have other resources. I mean, they're suffering, their lives are miserable, and the stimulation can really offer an improvement in the quality of life. And this is interesting. This is a systematic literature review. Over 50 years of experience. The entire literature was reviewed since the SCS was born 55 years ago. So with that, over 500 papers were selected initially, then 104, then it boiled down to 7 RCTs that pointed to a level evidence 1B+, meaning there are some, these studies are not perfect, but they are randomized control, and they are, then the advantage is surpasses much more the potential inconvenience related to the technique. So 1B level of evidence was demonstrated regarding improvement in functional capacity, quality of life, patient satisfaction across centers and studies was around 80%, and there is a sensitive reduction in analgesic medication. Regarding the pain score reduction, so it was statistically significant that tonic is superior, tonic stim, the conventional stimulation is superior to conventional medical management, and burst and high frequency were superior to tonic, which corroborates what we've seen so far. The DTM was not there because it's very recent. So, and how about cost effectiveness? Okay, we saw it's a good therapy, but is it cost effective? This Canadian study from 2013 compared the incremental cost effectiveness across 4 indications. Basically, sorry, it ended up to being too small, but this is for failed back surgery syndrome, CRPS, peripheral artery disease, and angina pectoris. And so the cost effectiveness ratio varied from 75 to 95%. In those cases, better for the vascular diseases, as we know from the European literature, not as much used here in the US. And this Italian study pointed to cost effectiveness of around 80 to 85% of the cases, and which was corroborated by this study from Spain, that around 5 years, around 79 to 80% presents a cost-effective profile compared to the conventional medical management. But it's important to note that the budget related to this study and that was almost half. So this was actually, if you compare, much more than that. But anyway, there are multiple studies pointing to a cost-effective profile. All right, and just to sum up the presentation and to bring some questions like to instigate, what should we do if SCS fails? For instance, if the patient has nothing else to be done in terms of spine surgery, no structural problem to be corrected. The patient failed a trial, for example, or had a long-term failure. What can we offer to those patients? It's important to remember that there is another option, which is the chemical neuromodulation with intrathecal medication with pumps. You want to avoid this as much as possible. Some people say you date a patient with spinal cord stimulation, but you marry a patient with the pump stim, because you need to refill the patient every month or every other month. You can have problems related to the catheter, like rupture or clogging. But it's very interesting as a last resource, especially for patients that want to avoid opioids, because it used to be called morphine pumps, but in fact, the recommendation is to start as much as possible with ziconotide, which is a non-opioid drug that selectively blocks voltage-gated calcium channel receptors, and it has no withdrawal if for any reason the patient cannot have it refilled or the system fails. So ziconotide is a very good alternative for especially for non-cancer related pain. And of course, different combinations are reported. Okay, and last question. What do we do in cases like this when the patients have pristine images? That's puzzling. So yes, conservative treatment, but sometimes if we look closer in the MRI, we see an important fat substitution in the multifidus. And then we can check if the prone stability test is positive. This means you ask the patient to stretch the legs without help, and if the patient reports pain that is relieved by a repetition of the maneuver, when you press the back against the table, stabilizing, accounting for the multifidus dysfunction, if the pain improves, those two, the imaging and the neuro exam, they point towards a multifidus dysfunction, which can be a source of chronic pain. So motivated by those findings and extensive preclinical data as well, so the pivotal trial was conducted in 26 centers in the US, Europe, and Australia. It's an Australian company, in fact, in which patients that had those findings and pain score from 6 to 9, disability from 20 to 60%, and they called virgin backs, they were never operated. They underwent the implant of this system. This is not spinal cord stimulation. This is called restorative neurostimulation, where the goal is to leave the lead over the TP of L3, sorry, to stimulate the dorsal rami, stimulating the multifidus muscle. So the patients, there is also it's a full implant. The IPG is implanted, so it's set the way that 30 minutes twice a day, it will trigger stimulation, like better conditioning the muscles to account for the muscle dysfunction. And it was recently approved by the FDA. And so I don't know if it is available yet. I need to check. But 4 years from the pivotal trial and the follow-up for 4 years showed that 76% of patients responded with around 60-65 improvement in the pain, reduction in disability, and reduction in medication or even discontinuation, because once you rehabilitate the muscles, the patients, then they can continue the rehab and sustain a long-term relief. So then comes the question, why they don't just exercise, or why don't we just send them to a very intense program of exercising and rehab? Because they have so much, they tried. All those patients were refractory to rehab. They tried, but they have so much pain. The process is so advanced that they were not able to have a meaningful rehabilitation of the muscle. Therefore, this was the start for them to get back on track and then continue to have the muscles in a good condition. So finalizing, we're not really driving the bus on the management of chronic pain. It really needs a multidisciplinary approach. It takes experts in all of the subspecialties involved, like PCP, pain medicine, neuropsych, psychiatry, PM&R is very important. Rehab is key to have a very well rehabilitation performed, anesthesia, and neurosurgery. Neurosurgery can also be of assistance in patients with chronic low back pain and radicular pain. So in summary, this is the last slide for us to have a message from the presentation. So pain has especially two components. Let's remember the somatic component and emotional component. So we have two pathways, lateral and medial, and we need to account for both when we want to meaningfully treat the patients. Nociceptive pain and neuropathic pain, the questionnaires can help us to identify and quantify those components. The FDA indication for SCS is chronic pain in the trunk and extremities. Great indications for us in the neurosurgery realm is failed back surgery syndrome, degenerative disc disease, and radicular pain, especially when neuropathic, clearly neuropathic. And naturally, when there is no other thing we can offer in terms of spine surgery to reestablish the structure, okay? Diabetic neuropathy, CRPS, peripheral artery disease, and angina pectoris are also great indications. The vascular diseases are a very common source, a very common indication for the procedure in Europe. It's still growing in the US. CRPS is actually, I believe there is studies accurate is the trial related to DRG for CRPS. This would be typically the best strategy to go DRG, but it's also when the DRG is not possible, is a good indication for spinal cord stim. So patient selection is the most important part. Without a very good selection, the results would not going to be as we expect. It's important to think about neuromodulation for chronic pain before strong opioids. Let's remember that. And SCS has demonstrated over 5 decades that it's an effective strategy, leads to medication reduction, improvement in quality of life and disability, and it's a cost-effective strategy in around 80% of the case. So thank you very much for the time I had to speak with you. Let's try to help our patients to become, to go back to and resume their life activities and have a very happy life.
Presentation.
Okay, so I'll be presenting on the history and evolution of treatments for carotid stenosis to how it evolved to the CEA and what we know it is today. And so I started thinking about this topic recently when Dr. Morcos was preparing his talk for the WFNS meeting in Bogota. And so I realized that neurosurgery hasn't always really owned the CEA, and it wasn't until recently that we took over the surgery from vascular surgery as the predominant force. And so we can't fully understand where we are now and where we're going in the future without knowing where we've come from and the history behind that. And so that's why I wanted to talk about the history and evolution of treatments for carotid stenosis. And so just to start, I just wanted to talk a little bit about the epidemiology, just to put things into perspective. And so stroke is a major, cause of morbidity and mortality in the United States. It costs the US $46 billion a year. And it's the leading cause of long-term disability in the United States and 5th cause of death in the United States. And so, stroke occurs in one person every 40 seconds, and then death from stroke occurs every 4 minutes. And so also carotid artery stenosis accounts for about 20-30% of ischemic strokes. And so it's actually a really big and significant problem. And so, wanted to focus first on the history of carotid stenosis and how it was discovered. And so, our current understanding of stroke and carotid artery disease really starts from the ancient Greeks. And so, since the early times, the ancient Greeks knew how important the carotid artery was. And so they knew that by compressing the carotid artery, it would cause loss of consciousness. And so the word carotid is actually derived from karos, which means to stupefy. And so, in this artwork, even from that century, in Athens, it shows this centaur is compressing, his opponent's artery and to induce unconsciousness. And so, the first person to actually describe stroke was Hippocrates in 400 BC. And in his book, he actually called it apoplexia at that time, which means to strike down. And so in that book, he also discussed, apoplexy. He thought that it was linked to the humoral theory, in which the body is composed of these four humors. And so it's blood, phlegm, black bile, yellow bile, which is seen in these pictures here. And so when these four humors are in balance, we're healthy, but when they're out of balance, then that's when disease occurs. And so this hypothesis was also supported by Galen in 200 AD. And so he actually developed this idea of this vital spirit in the heart. And so he thought that the vital spirit was carried to the brain. And then once it gets to the brain, it's actually changed by this retiform plexus into this animal spirit. And this animal spirit is what was thought to be the fuel for motor and sensory impulses to the periphery. And so with the humoral theory, they thought that in patients with apoplexy, there's this phlegm that accumulates in the body. And, this coldness of the phlegm causes the blood become still. And as the phlegm becomes more predominant, then the blood is further cooled and congealed. And then the phlegm eventually blocks the flow of the animal spirit, resulting in this weakness and sensory dysfunction, loss of consciousness, and eventually death. And so this was the predominant theory for about 1500 years until the 17th century, when Wepfer in 1658 challenged this theory. And so in his book, Historia Apoplectorium, he actually wrote about 4 different autopsies in patients that had apoplexy. And so when he opened the brain, he actually discovered that there was no black bile, there's no phlegm, no humors in the brain. And instead, he found that there was this occlusive thrombus in the carotid artery. And so he was the first to postulate that it was an interruption of blood supply to the brain that was the cause of apoplexy, and not an imbalance of these humors. And so at this time, he still wasn't sure whether thrombus in the carotid was due to embolization from the heart, or if it was from an in situ thrombus, because atherosclerosis hadn't yet been established as a theory yet at that point. And so then 6 years later, in 1664, Thomas Willis actually expanded on the work of Wepfer and others and published in his book Cerebri Anatomy. And so in this book, he wrote about the vascular ring in the brain, which is now called the Circle of Willis. And interestingly, he actually wasn't the first to describe the Circle of Willis, but it was only named after him because the importance of the Circle of Willis was only confirmed after he did an autopsy on a man that was neurologically intact before death. And so in this book, he saw that in the autopsy, it revealed that there was a occluded right carotid artery. And so the patient, even though the patient was neurologically intact. And so this showed that the brain could survive with only one carotid artery and that you didn't need two. And so then in 1754, Van Swieten, about 100 years later, he was the first to suggest that an embolism from the heart could be the cause of stroke or apoplexy. And so then 100 years later again, Abercrombie, in his book on diseases of the brain and spinal cord, he was one of the first people to present a case of calcified carotids at autopsy of a patient who died of apoplexy. And he described it as that it was ossified and that their coat was really thick. And so this was the first step towards understanding of atherosclerosis. And so then a few years later, Savory actually expanded on his theory. And in his book, he described this patient with this opaque yellow deposit in this carotid artery that you see here, and saw that it was completely contracted and filling the entire carotid. And he also noticed that in the brain, on the same side, there was the brain was disorganized superficially. And so he thought that this was the first correlation between carotid atherosclerosis and cerebral ischemia. And so then later that century, Chiari furthered the theory of atherosclerosis even more and described these ulcerating plaques that you see in this picture here. And he found that they were at the carotid bifurcation. He thought that these, atherosclerotic plaques could break away and embolize into the brain and cause strokes. And so, he was the first to propose this link between atherosclerosis at the carotid bifurcation, causing cerebral emboli and subsequent stroke. And so prior to this, it was only thought that emboli were originating from the heart, and, no one really thought that they would come from anywhere else. And so, now, in 1951, there was a landmark article written by Miller Fisher. And so in this article, he looked at the carotid arteries during autopsies of patients with strokes and documented, how often the carotid was stenosed, in what degree it was occluded, and noted, when the carotid was the only lesion that it could be the explanation of the stroke. And so this article was really what made the final link between carotid stenosis as a cause of the stroke. Prior to this, the stroke was thought to be due to thrombosis of the MCA or lenticular striates or due to vasospasm. He also made this famous statement in this book back then that said, it is even conceivable that someday vascular surgery will find a way to bypass the occluded portion of the artery. And so, by the early 1900s, the pathophysiology of carotid stenosis had pretty much been understood. And so now people started beginning to develop approaches to treat carotid stenosis. And so the first carotid reconstruction was done actually in 1951 by Korea, followed by Escott in 1954. However, these were just end-to-end reconstructions and not really true endarterectomies. And so with Korea, he actually cut this distal, this is the plaque, and so he cut the distal portion of the ICA and then reimplanted it onto the ECA. And then for Escott, he did a variation of that procedure, and so he completely cut out this occluded segment and then reimplanted this ICA onto the common carotid artery. And so it wasn't until DeBakey in 1953 that first did the first successful endarterectomy, which is what we do today. And so then, a few years later, actually in that same hospital as DeBakey, Cooley pioneered the CA with the intravascular shunt at Methodist Hospital. And so, his patient had neurological changes about 30 seconds after temporary carotid occlusion. And so he decided to use this polyvinyl shunt to maintain flow in the ICA while the plaque was being removed. And so he was the first to discover that. And then a few years later, there started beginning a search for less invasive techniques for carotid stenosis because, with the CEA it was pretty invasive. And so in 1967, DeBakey looked at and developed open carotid angioplasty, but this was for fibromuscular dysplasia and it wasn't for carotid stenosis yet. And so after he gained access to the carotid artery, he actually made this transverse cut in the carotid artery and then inserted this biliary dilator to serially dilate the carotid artery. And so nothing had been done yet for carotid stenosis yet until 1987 when Theron and his colleagues developed the first series of carotid balloon angioplasties. The only issue with that was that he noted about 8% embolic complications and 5% risk of carotid dissections. And so with these high rate of embolic complications, it actually prompted a search for different ways to be able to protect the brain during these procedures. And so, a few years later, he actually developed this triple coaxial catheter system that you see here on this right side. And so the balloon, there's this distal balloon that is inflated to prevent emboli. And so you first inflate the balloon, and then once you angioplasty the stenosed portion, there's usually these particulates that are left behind. And so these can actually be aspirated before this angioplasty balloon is deflated. And so this helped to decrease the rate of embolic complications down to about 0%. And so, however, despite this, there was still the complication of this carotid dissection due to this wall shear stress when you're trying to angioplasty the vessel. And so this again prompted another search for new techniques. And so in 1966, several different papers were written about stenting. And so they saw that in the cardiology literature, stenting was actually being used for coronary arteries, and they had better outcomes than angioplasties. And so researchers started applying this to carotid stenosis. And so, several different stents were designed, and with use of these stents, they actually saw that there was, again, a lower rate of restenosis and carotid dissections than before. And so, that was kind of the evolution of how carotid stenosis was discovered as an entity that can cause stroke, and how, the different treatments evolved over time. And so now I just wanted to talk about the different landmark trials and evidence behind treatment of carotid stenosis. And so the first paper was, in 1970 to 1980s, the CEA kind of became the go-to procedure for treating carotid stenosis. And it was being done more and more frequently. And as you can see here, it was being done for TIAs, stroke. And so the main reason why they were doing that was because there were natural history studies that suggested the risk of recurrent stroke in patients with symptomatic carotid stenosis was pretty high, and it was 26% in the first 2 weeks if it was left untreated. But there were other reports indicating that the expected complication rate and stroke rate and death rate after CEA was only 0 to 5%. And so because of these studies, CEA seemed more appealing to the low complication rate compared to the natural history risk of untreated symptomatic carotid stenosis. And so later there was a study in 1977 that then raised the question about perioperative morbidity and mortality rate with CEAs at 2 different hospitals, and so community hospitals. And so they looked at 11 surgeons in these 2 hospitals and found that out of these 11, 7 of them actually had a stroke and death rate between 17 to 20%. And the total stroke and death rate in the whole cohort was about 21%. And so they argued that, because the rates of stroke and death between all these different surgeons were pretty similar, they thought that, this was going to be representative of surgeons at other community hospitals as well. And so now, with this high complication rate, the study started making CEA seem less appealing than medical management. And so at this time, many neurologists started beginning to treat their patients medically and avoided recommending surgery for their patients. And so because of this is what then led to all these randomized trials like NACIT, ECST, ACAS, ACST, to look at whether CEA or best medical management was better. And so here's just kind of a summary really quickly of the landmark trials that we'll talk about. And so, there's many different trials. It can get really confusing because all the acronyms, but just wanted to put this here to try to summarize a few of these landmark articles. And so I thought that this was a pretty good way to categorize it so it's less confusing. So there's trials for CEA versus medical management, and you can divide that into the symptomatic versus asymptomatic group. And then there's also trials for CEA versus stenting, and that can be divided again into symptomatic and asymptomatic groups. And so, the main treatments for carotid stenosis, as we know, are medical management, CEA, and stenting, and this new technique called Tcar, which is transcarotid artery revascularization, which I'll talk about later at the end. And so first, for medical management, it's recommended for any patient with any atheromatous lesion. And so it's based on lifestyle modification, diet, exercise, smoking cessation, and pharmacological treatment, which is like antihypertensives, high potency statins as much as the patient can tolerate, and anti-platelet therapy. And so you can see here on the right with this group 8, when the patients have all 4 risk factors managed, the rate of stroke, TIA, carotid revascularization in the future, and carotid stenosis progression is less than in the group 1 when they have none of the risk factors managed. And so in regards to the antiplatelet therapy, there are several different studies that have investigated different antiplatelets and different anticoagulants to see which one is better in reducing the strokes. And this is just a few of them. There's many, many different others. I'm not going to go into all these details about these different antiplatelet therapies because it's not the main point of the talk, but I just wanted to list it out just so you're aware when you see these abbreviations like Capri, WASID, Caress, Profess, Claire, and Socrates. So these are all just talking about antiplatelet therapy, anticoagulants. And so, for example, with Capri, it looked at clopidogrel versus aspirin. With WASID, it looked at warfarin versus aspirin. With Profess, it looked at aspirin versus, clopidogrel and prevention of stroke. And so, now we'll talk about the evidence for CEA and symptomatic carotid stenosis. And so the first study, as we all know, is the NACIT trial. And so this was from the early 1990s. And so it actually took patients with symptomatic carotid stenosis, 70 to 99% stenosis, and compared medical management versus CEA. And so they saw that the risk of stroke in these patients with CEA was 9%, but with medical management, it was 26% at 2 years. And so they made the conclusion that, CEA was highly beneficial for these patients with high-grade symptomatic carotid stenosis of greater than 70%. And so, then they had these other patients that were in the 50 to 69% stenosis range. And so they also looked at these patients as well. And so they noticed that the stroke rate for CEA was about 15.7%. And then for medical management, it was 22% at 5 years. And so this was still a significant difference, but the difference wasn't as big as the prior trial, of 9 and 26%. And so this data, though, supported, CEA for moderate symptomatic carotid stenosis of 50 to 69%, as long as, the patients are symptomatic from their carotid disease. And so, in summary, the NASCET trial really recommended CEA if the patient had greater than 50% stenosis and they were symptomatic. And, this is still the cutoff criteria that we use for symptomatic carotid stenosis. And so then the second study for symptomatic patients was an ECST study. And so this was really a European study that looked at similar thing as NASCET. And so looked at medical management versus CEA and looked at the risk of stroke. And so they found that for CEA, the risk of stroke after CEA was 15%, about 15%. And for medical management, it was 26% at 3 years. And so, this wasn't as much as the NASCET trial, but it still was significant enough. And so they recommended the same thing as the NASCET study, which was, that CEA is indicated in symptomatic carotid stenosis greater than, 80%. And so, the reason why NASCET and the ECST had different cutoff rates for symptomatic carotid stenosis was because of this. And so because of this thing on the left. And so with NASCET, if you remember, I said that the NASCET trial said that CEA would be beneficial for patients greater than 50% stenosis, but ECST said it was beneficial for patients with 80% stenosis. And so the reason is because of the difference in how they measure the carotid stenosis between the two studies. And so the ECST trial actually measures carotid stenosis with the diseased portion of the artery, including this plaque. But then the NASCET trial only measures the undiseased carotid and doesn't include the plaque. And so with the ECST trial, it actually overestimates the degree of stenosis. And so for 50% stenosis in NASCET is about equal to 75% in ECST. And so that's what the difference is. And so now we'll go into the evidence for asymptomatic carotid stenosis and whether we should do CEA versus medical management in asymptomatic patients. And so the first trial that we'll talk about is the Acas trial. And so this, trial looked at asymptomatic patients with about greater than 60% stenosis. And they noticed that at 5 years, patients in the surgical group had 5% risk of stroke versus in the medical management group, it was 11% risk of stroke. And so they saw that this was a significant difference, and it was significant enough that it actually made people start treating asymptomatic carotid stenosis with CEAs. But, if you look back at this data, it's actually the difference between it's not that significant. It's only, decreases risk of stroke by half, which sounds like a lot, but, you're really talking about the risk of stroke in asymptomatic patients is only 2%, and with medical management, and then with CEA it goes down to 1%. So it's really not that big of a difference. Then 10 years later, the ACST trial came out and they looked at immediate versus deferred CEA in asymptomatic patients, again, with greater than 60% stenosis. And so the deferred CEA patients were patients that were asymptomatic, but they didn't get CEA until they developed symptoms or some other indication for surgery. And so, in this study, they found similar as Acas in that the risk of stroke for CEA was 4%, for medical management was 10% at 5 years, and then at 10 years, in CEA was 10%, and medical management was about 17%. And so, similar to the Acas trial, they concluded that immediate CEA, reduces the risk of stroke in asymptomatic stenosis patients with greater than 60% stenosis. And so, now, that was trials about patients who are healthy and who can get surgical intervention. But, what about the people who can't get CEAs because they're high risk of complications with CEA? And so these high risk patients are, patients with prior neck surgery or radiation, patients that had prior CEAs that been restenosed or had contralateral, laryngeal palsy already, or contralateral occlusion, older patients, or patients with like heart or severe pulmonary issues. And so in these patients, they're at high risk to undergo anesthesia. And so if we can, avoid CEA, then we want to try to do that if possible. And so, endovascular techniques started being created in the 1990s. And so the Sapphire Trial was really a non-inferiority trial to look at stenting versus CA in these high-risk patients. And so they compared protected stenting versus CA in these patients with symptomatic stenosis greater than 50% or asymptomatic stenosis greater than 80%. And when you look at the graph, it looks like there is a difference initially, but then these confidence intervals end up overlapping. And so they found that there was no difference in stroke at 1 year and 3 year between the two groups. And so they concluded that protected stenting is not inferior to CA. And so, at this time, the Medicaid actually approved stenting for symptomatic high-risk patients greater than 70%. And so now, we'll talk about the evidence behind CA versus stenting in symptomatic and asymptomatic patients that are not high risk. So different than this last trial, the Sapphire Trial, which is for patients at high risk of stenosis. And so this is the Ecst Study. And so the Ecst Study, in 2010, when they reported it, it actually compared CEA versus stenting in these patients with symptomatic stenosis greater than 50% or asymptomatic stenosis greater than 60%. And so they saw here that with stroke, the rate of stroke, stenting actually had a higher risk of stroke than CEA, and this was statistically significant. And with MI, there was a higher risk of MI in the CEA group than the stenting group, and this was also significant. But when you put all these together and compare the primary endpoint of just any stroke, MI, death, that there was no difference between these two groups. And so they also followed these patients over the next 10 years. And so then in 2016, they published the long-term results of this study. And so they reported that, there was no significant difference in respect to periprocedural stroke, MI, or death and subsequent ipsilateral stroke between the two groups. And so now we'll talk about the evidence behind CEA versus stenting in symptomatic carotid stenosis patients. And so the first study that we'll talk about is the ICSS. And so this is a European study, and it looked at patients that were suitable for CEA and stenting. And so these were not the high-risk patients that we talked about earlier. And so they compared CEA and stenting, and you can see here that with CEA, there's lower risk of stroke than with stenting. And so they concluded that CA was superior to stenting for stroke, death, or MI at 120 days for patients with symptomatic stenosis greater than 50%. Then they followed these patients over 5 years and then published long-term outcomes 5 years later. And actually at 5 years, they found that these groups actually evened out, and there was no difference between the stenting and the CEA group in terms of long-term functional outcomes and risk of fatal or disabling strokes. And so then the second trial that we'll talk about for symptomatic carotid stenosis is the EVA-3S trial. And so this was a French study. It was a non-inferiority trial that was looking at CA versus stenting in symptomatic patients greater than 60% stenosis. And this trial was actually stopped prematurely because they found a significantly higher rate of death and stroke in the stenting group compared to the CEA group. And so the main conclusion of the study was that CEA is superior to stenting. However, one of the main criticisms of the study was that they included centers with insufficient experience to do these stenting procedures. And so, these centers only really needed 12 procedures to be able to participate in the trial. And so, the last trial that we'll talk about for the symptomatic carotid stenosis is the SPACE-1 trial. And so this was, again, a non-inferiority trial that looked at CA versus stenting. And so this trial was terminated early due to funding issues, but when they reported the results, they found no difference in the incidence of stroke or death at 30 days. And so, now we'll talk about the evidence behind CA versus stenting in these asymptomatic patients. And so with the first study is the ACT-1. And so that looked at CA versus protected stenting in these asymptomatic patients with greater than 70% stenosis. And so they actually showed here in this Kaplan-Meier curve that there's no difference between stenting and CA in regards to death, stroke, or MI at 1 year, and at 5 years, a stroke for follow-up. And so then the second study is the Acst-2 trial. And so, previously we had talked about the Acst-1 trial, which looked at CA versus medical management in asymptomatic patients. Now the Acst-2 is looking at CA versus stenting instead of medical management in these asymptomatic patients. So if you look at the Kaplan-Meier curves, you see that there's no difference in procedural stroke or death within 30 days, and at 5 years between these two groups, they also found that there was no significant difference. And so now, the next trial is the SPACE-2 trial. And so, there was a SPACE-1 trial that we talked about earlier. And so with the SPACE-1, again, it looked at CA versus stenting in symptomatic patients, but in SPACE-2, its aim is to look at asymptomatic patients and wanted to compare medical management alone versus medical management in CA or medical management in stenting. And so this was for patients with greater than 70% stenosis based on the ECST criteria, not the NACIT criteria. And so initially, they planned to enroll 3,500 patients, but due to low recruitment, they actually stopped the trial prematurely and only enrolled about 513 patients. And because of the low sample size, they ended up concluding that the power wasn't sufficient to show CA or stenting was superior to medical management. And so they're going to continue that trial later. So, those were all the landmark trials that we just discussed. And because in these trials, it showed that there was higher risk of periprocedural stroke with stenting. And so I wanted to talk about, the 3 different ways that you can get stroke during stenting. And so the first way is, when you're passing the catheter up through the aortic arch. If the aortic arch is really calcified, then these calcification plaques can flick off and cause emboli and cause a stroke. And so the second way is, whenever you're placing the emboli protection device that I showed earlier with that balloon or something similar to that, you have to first cross this stenotic portion unprotected. And so when you cross this portion, there's a risk of this emboli flicking off and causing a stroke. And then the third way, is when you're doing the actual procedure itself during angioplasty or stent deployment, or when you're retrieving the emboli protection device, you can also get these embolic plaques that flick off and cause a stroke. And so so we can try to eliminate some of the risk of the stroke by avoiding having to go through the aortic arch to get to the common carotid artery. So with this Tcar technique, the new technique with transcarotid artery revascularization, you actually have access to the common carotid artery directly instead of having to go through the femoral artery. So you don't have to go through this aortic arch anymore. And so this is an illustration of what the Tcar looks like. And I just wanted to show this video real quick of how it works. So with this Tcar, you get direct carotid access, and then you insert this device into the carotid. And then the flow initially is this way, but then once you clamp the CCA proximally, you get reverse flow. And so this flow is reversed from the carotid, and then it goes into this femoral vein, and it's recycled this way. But then this blood actually goes in through this filter. And this filter, you can turn on low and high, but it's designed to pick up the embolic material before returning the blood in to the body. And so here, you can deploy the angioplasty and then deploy the stent, and then, which you see here. And so, all this embolic material that could have been here will be picked up by this filter. And so with this Tcar, it's designed to have less risk of stroke because you don't have to, number one, go through the carotid or through the aortic arch, and you don't ever have to cross the area of stenosis unprotected, like with the embolic protection devices. And so just to talk about the evidence for Tcar, so this is the Roadster Trial. And so the Roadster Trial was looked at 141 high-risk patients at 18 different sites. And so it actually showed that the stroke rate with Tcar was 1.4%, which was the lowest reported stroke rate ever. And so this was compared to, in the Ecst trial that we talked about earlier, the CA, the rate of stroke was 2.3%, and for stenting, it was 4.1%. And so, because of this, the Tcar was actually approved by the FDA in 2015 for use in these high-risk patients. And so, because it was such a small sample size, the FDA actually mandated them to get a larger sample size. And so they came out with the Roadster 2 trial. And so with the Roadster 2 trial, they actually enrolled 690 patients and then over 43 sites. And what was important was that they had to get 80% of the surgeons had to be surgeons who had never used the Tcar before in the past. And so with this, they even showed a better stroke rate. So there was 0.6% rate of stroke for these high surgical risk patients. And so just a little evidence behind Tcar versus CEA. And so in this trial, they had about 5,700 patients, and they actually found that there was no difference in ipsilateral stroke or death. But when they looked at in-hospital MI, stroke, death, cranial nerve injury, the Tcar was associated with lower risk of that and a shorter hospital stay. And so some evidence for Tcar versus stenting, they had 3,282 matched pairs. And so they saw that Tcar versus stenting, Tcar was associated with lower risk of stroke and death, but there was no real difference in risk of MI, which is right here. And so the current ongoing trials are Ecst 2. So they started enrolling patients in December of 2014. And then they estimate the completion date as this December. And so it's mainly looking at medical management versus CEA compared to medical management alone, and then medical management and stenting versus medical management alone. And so just in summary, with the current practice guidelines, medical management is used for all patients. And so CEA is the first line for patients with symptomatic carotid stenosis greater than 50%. And and they think it's reasonable to consider CEA in asymptomatic patients with greater than 70% stenosis if the pre-op stroke and death and MI rate is less than 3%. And so stenting is currently only FDA approved for symptomatic high-risk patients with greater than 70% stenosis, but prophylactic stenting can be considered for some highly selected patients. But the effectiveness compared to medical management isn't really well established at this point. And so that's it.
Hey, Eva, great job. You managed to navigate that whole talk without talking about subspecialties, even though you started with, I think, maybe I misinterpreted what you were saying, that Dr. Marcos said that neurosurgery is now dominating the field in CEA. Did I misinterpret what you said?
Yeah, so with some of the studies that I looked at, there actually was, a lot of the studies, the neurosurgery did a lot of them, but just with the Tcar is when vascular started doing more than neurosurgery. It was like 80% vascular surgery, or like 80% vascular surgery, like 10% IR, and it was like 2% neurosurgery.
Right. So I mean, that was my understanding when I looked at this data, both locally and nationally for LEAP, you know, because it's part of leapfrog evaluation. So, you know, we are a relatively small player in the field, both open and endovascular. And so any ideas on how neurosurgery can gain strength in that field in terms of just doing the volume? I mean, I don't think we do more than 10 cases of open a year here.
Yeah, I'm not really sure, like, you know, how we can get more. I guess maybe just have neurologists, you know, refer the patients to us instead of vascular. I mean, is really the only thing I can think of.
I think a lot of it has to do with, you know, like you said, referral patterns and how these things get worked up. And a lot of the stuff is done with screening ultrasounds to start with. And I think that sort of is a big factor in how patients get diverted. And thank you for doing that talk.